Welcome back to the deep dive. We're doing something very specific today. I want you to close your eyes for a second. Imagine you're standing in a hallway. The air conditioning is humming. You're wearing slightly uncomfortable formal wear, and your palms are just a little bit sweaty. You're standing outside the exam hall for the Gujarat University MD Anesthesiology finals. You're waiting for the viva voce, or perhaps you're about to sit down for the theory paper.
That is a feeling every anesthesiologist knows intimately. That mix of adrenaline and the fear that you might have forgotten a dose or a key physiological principle.
Exactly. And the topic we're diving into today is one of those subjects that seems, deceptively simple. It's the bread and butter of your daily life in the OT. You hang these bags every single day. We're talking about intravenous fluids, crystalloids, and colloids.
It's the absolute foundation of our practice. And honestly, it is a minefield in the exam. It sounds basic, salt water versus starch. But in an MD exam, this is often where the examiner decides if you're truly safe to practice. Oh yes, if you don't understand fluids, you don't understand physiology. And if you don't understand physiology, well, you're not going to pass. It's that fundamental.
So our mission today is to build the ultimate, comprehensive, exam-oriented audio guide to this topic. We aren't just skimming the surface. We've pulled from the heavy hitters. Miller's Anesthesia, Morgan and Mikhail, the ICU book by Marino, and of course, Guyton's Physiology.
And we've also looked at specific question patterns from the DNB and Gujarat University exams to make sure we cover the exact phrasing and concepts they look for.
That's key.
I'll be taking on the role of your senior faculty mentor today. Think of this as a final revision session before you walk into that hall. We are going to structure this exactly how you should structure a long answer question.
Okay, how are we going to do that?
We'll start with the introduction and definitions, move to the high-yield physiology, specifically the revised Starling forces, which is a big one. Then we'll deep dive into crystalloids, then colloids, compare them, and discuss clinical scenarios.
At the end.
Finally, I will tell you exactly how to draw the diagrams and write the conclusion to secure those extra marks that make the difference between a pass and a distinction.
Perfect. Let's get straight into it then. Section 1, the introduction. If I get a long note asking about intravenous fluid therapy or rational fluid therapy, how do I begin? I can't just start listing fluids, can I?
No, absolutely not. That's a rookie error. You need to frame the answer. You must define intravenous fluid therapy as a therapeutic intervention.
Okay, so not just giving water.
Not at all. It is the administration of fluids to maintain effective circulating volume and prevent inadequate tissue perfusion. You have to start with that purpose.
So you're saying I should treat it like a drug?
Precisely. You must treat it like a drug. It has indications, contraindications, and dose-dependent toxicity. For the anesthesiologist, fluid management sits right alongside the classic triad of anesthesia, unconsciousness, pain relief, and muscle relaxation. You're managing the physiological milieu in which all those other drugs work.
Right, and the specific goals we're trying to achieve with this drug.
The purpose is threefold, and you should state this clearly. First, to preserve the body fluid compartments and avoid dehydration. Second, to maintain effective circulating volume to ensure cardiac output and oxygen delivery.
And the third?
And third, to replace specific losses, whether that's insensible loss from the lungs and skin, urinary output, or, surgical bleeding and third space losses.
Why do you think examiners are so obsessed with this topic?
Because it's high stakes. Inappropriate fluid therapy leads to significant morbidity. Give too little, you get hypoperfusion, organ failure. Give too much, and you get tissue edema, alesis, respiratory failure, and surprisingly, even kidney injury.
So they're testing for safety.
They're testing for respect. They want to know that you respect the fluid. You'll see questions like, classify 4 fluids, compare crystalloids and colloids, or short notes on balanced salt solutions or Starling forces. In the Viva, they'll grill you on the physiology.
Speaking of physiology, that's a perfect transition. Let's move to Section 2. This is marked in our notes as very high yield, the basic physiology of fluid distribution.
It is. You simply cannot explain the pharmacology of fluids if you don't understand the anatomy of water. You have to start with the body fluid compartments.
The famous 60-40-20 rule.
Yes, but let's be more precise for the MD level. Total body water, or TBW, is approximately 60% of lean body weight in an adult male. In an adult female, it's closer to 50%.
And why is there that difference?
Adipose tissue. Fat is hydrophobic. It contains very little water compared to muscle. Females physiologically have a higher percentage of adipose tissue.
And this changes with age and weight too, right?
Absolutely. The percentage drops in the elderly because of sarcopenia muscle loss, and it drops significantly in obese patients. In a morbidly obese patient, TBW might be as low as 40% of their total body weight. This is crucial when you're calculating fluid deficits based on weight.
Okay, so we've got our total body water. How do we slice this pie for the exam answer?
Imagine a big box representing that 60%. Now we divide it into two main compartments. 2/3 of all that water is intracellular fluid, ICF. It's the fluid inside the cells.
And the other third?
The remaining 1/3 is extracellular fluid, or ECF.
And as anesthetists, we're mostly playing in the ECF sandbox.
Correct. But we need to subdivide the ECF again for a complete answer. 3/4 of the ECF is interstitial fluid. That's the water bathing the cells, the fluid outside the vessels.
So only 1/4 of the ECF is actually in the bloodstream.
Exactly. Only 1/4 of the ECF is plasma volume. That's the intravascular space.
Let me just do the math on that for a second. For a 70-kilogram man, TBW is 32 liters. So ICF is 28 liters, and ECF is 14 liters.
Go on.
And 1/4 of that 14 liters. So plasma volume is only about 3.5 liters.
Precisely. That tiny 3 to 4 liters of plasma is what keeps the patient alive. It's what generates the blood pressure. The entire goal of resuscitation is to keep that little bucket full.
What about transcellular fluid?
Good question. You should mention it for completeness. It's the small compartment of CSF, synovial fluid, pleural fluid. But for general fluid dynamics, its volume is negligible.
Okay, now for the really important part. What determines where the fluid goes? This brings us to the Starling forces. I remember learning that hydrostatic pressure pushes fluid out and oncotic pressure pulls it in.
That is the traditional Starling view. Ernest Starling described that back in 1896. If you recite that, you will pass. But if you want to impress the examiner,
Which I do.
then you need to explain the revised Starling principle and the Glycocalyx model. This is straight out of the newer editions of Miller and Goten.
Okay, let's unpack the Glycocalyx. It sounds like something from a sci-fi movie.
It does, doesn't it? The endothelial glycocalyx layer, or EGL, is this delicate gel-like mesh of glycoproteins and proteoglycans that lines the luminal surface of the endothelium.
So it's like a fuzzy carpet on the inside of the blood vessel.
That's a perfect analogy. It is a fuzzy carpet. And this carpet contains a lot of plasma proteins, but crucially, it creates a specific zone right next to the endothelial cells called the subglycocalyx space.
And why does this space change the physics of fluid movement?
In the old model, we thought the oncotic pressure gradient was between the plasma and the general interstitial fluid, which has some protein in it. But the revised principle states that the gradient is actually between the plasma and the subglycocalyx space, which is virtually protein-free.
So the pull-keeping fluid inside the vessel is much stronger than we thought.
Much more effective. The gradient is steeper.
I've heard there's a Viva trap here regarding reabsorption.
A huge Viva trap. In the old model, we taught that fluid filters out at the arterial end of the capillary and gets reabsorbed at the venous end.
Right, that's what I learned in medical school.
And it's wrong. The revised Starling principle says that at a steady state, there is no significant reabsorption at the venous end. Filtration drops to near zero, but it doesn't reverse.
So fluid only leaves the capillary. It never comes back in through the capillary wall.
Correct. So how does it get back to the heart?
The lymphatic system.
The lymphatic system. The lymphatics are the vacuum cleaner. They actively pump that filtered fluid back into the venous circulation. This explains why, when you overload a patient with fluids, you can develop edema so quickly, you've simply overwhelmed the lymphatic drainage capacity.
This is absolutely critical for understanding why crystalloids and colloids behave so differently.
It's the whole game. Crystalloids are small molecules, salts, glucose. They pass freely through the glycocalyx and the endothelial pores. They go wherever sodium goes.
The colloids.
Colloids are large molecules, albumin, starches. They cannot pass through a healthy glycocalyx. They are trapped in the intravascular space, generating that powerful oncotic pressure.
Which leads us perfectly to section 3. Crystalloids. Let's start with a clear definition for the exam.
Crystalloids are aqueous solutions containing low molecular weight ions, so salts, or small organic molecules like glucose. The key property is that because they are small, they pass freely across the capillary membrane.
And we classify them based on their tonicity relative to plasma.
Exactly. We have isotonic fluids, which have an osmolality similar to plasma, like 0.9% saline or Ringer's lactate. Then hypotonic fluids with a lower osmolality, like 0.45% saline or 5% dextrose. And finally, hypertonic fluids with a higher osmolality, like 3% saline.
Let's do a deep dive into the specific fluids, starting with the most common bag in the world, 0.9% saline, aka normal saline.
And here's the first thing you say in the Viva. You look the examiner in the eye and say, "Sir, normal saline is not normal."
Go on, why not?
Physiological plasma has a sodium of about 140 MEqL and a chloride of around 98 to 100. The pH is 7.4. Normal saline has a sodium of 154 and a chloride of 154.
Whoa, that's a lot of chloride.
It's super physiological, and the pH of the bag is around 5.0. It's quite acidic.
So what's the clinical consequence of that high chloride?
When you give large volumes of saline, you cause a hyperchloremic metabolic acidosis. The kidney has to handle that massive chloride load, and through mechanisms described by Stewart's strong ion difference theory, this results in a decrease in bicarbonate.
And does that acidosis actually matter to the patient?
It can. It's been shown to cause renal vasoconstriction, potentially reducing the glomerular filtration rate, the GFR. It also causes confusion in the post-op period because you see a base deficit and you start thinking the patient is bleeding or septic, when actually they're just salty.
So with all those problems, why do we still use it so much?
It's cheap, it's stable, and crucially, it's compatible with blood products. You can't mix blood with Ringer's lactate.
Why not?
Because the calcium in Ringer's can cause the citrated blood to clot in the IV line. Also, as we'll discuss, saline is the preferred fluid for neuroanesthesia.
Okay, so let's talk about the solution to the saline problem.
Yeah.
The balanced salt solutions.
Right.
Ringer's lactate or Hartmann's solution.
These are specifically designed to be more like plasma. Ringer's lactate has sodium of 1 to 30, chloride of 109, much closer to normal. It also has a little potassium and calcium.
And it uses lactate as a buffer.
Exactly. Because the chloride is lower than the sodium, you need a negative ion to balance the charge. You can't put bicarbonate in the bag because it's unstable and precipitates, so they use a buffer precursor, lactate. The liver then converts that lactate into bicarbonate.
And that conversion process actually consumes hydrogen ions, so it has an alkalinizing effect.
Precisely. It counteracts acidosis. A common myth, by the way, is that you can't use Ringer's in liver failure. In reality, unless the patient is in fulminant liver failure or severe shock liver, they can metabolize the lactate just fine.
What about the newer balanced solutions like Plasmalyte?
Plasmalyte is arguably a better design. It uses acetate and gluconate as its guffers. Acetate is metabolized by muscle, so it's completely independent of liver function. It also contains magnesium and has a pH of 7.4 right out of the bag.
So it's basically artificial plasma.
It's the closest thing we have. The only downside is that it's more expensive than Ringer's or Saline.
Now let's talk about dextrose. 5% dextrose, or D5W. Is it a resuscitation fluid?
Absolutely not. This is a massive red flag in exams. You must be clear on this.
Explain why it's so bad for resuscitation.
In the bag, it is isotonic with an osmolality of about 252. But as soon as you infuse it, the glucose is rapidly taken up by cells for energy. What are you left with?
Just water. Free water.
Pure free water. And free water distributes across all body compartments, intracellular and extracellular.
So if I give 1 liter of D5W, how much actually stays in the plasma volume?
Only about 1/12 of it, maybe 80 to 90 milliliters. The rest floods the interstitial space and, crucially, the intracellular space. If you try to resuscitate a trauma patient with D5W, you will cause cerebral edema and life-threatening hyponatremia long before you fix their blood pressure.
So its only use is for replacing a free water deficit, like in hypernatremia, or as a vehicle for drugs.
Correct. For maintenance calories in water, not for volume.
Let's talk about the volume effect of crystalloids in general. You hear about the 3-to-1 rule.
Yes, and it's a direct consequence of the physiology we discussed. Because crystalloids distribute across the entire extracellular fluid space, both interstitium and plasma, only about 20 to 25% of what you infuse actually stays in the vessel after 30 minutes.
So to replace 100 milliliters of blood loss, you need to give 300 to 400 milliliters of crystalloid.
Exactly. This is why we call them volume inefficient.
So to summarize for an exam answer, what are the main advantages of crystalloids?
They are cheap, they are widely available, they're non-allergenic, and they preserve urine output. Very safe from an allergic standpoint.
And the disadvantages?
The duration of action is very short. The volume effect is gone in 20-30 minutes as it shifts into the tissues. And the big one is tissue edema. If you pump in 4 liters of saline to replace 1 liter of blood loss, those extra 3 liters end up in the lungs, the gut, and the skin.
Which leads to what we call fluid creep.
Fluid creep. Poor wound healing, anastomotic leaks, pulmonary edema, a whole host of problems.
Which brings us to the competitors designed to avoid that very problem. Colloids. Section 4.
Yes. Colloids contain large molecules. The definition is usually a molecular weight greater than 30,000 Daltons, or 30 kilodalton. They are, in theory, too big to cross a healthy endothelial barrier.
And we classify them into natural and synthetic.
Natural is simple. Human albumin. The synthetic category is broader. It includes gelatins, dextrans, and the hydroxyethyl starches, or HES.
So what's the fundamental mechanism of action here?
They work by increasing the plasma oncotic pressure. They hold water in the vessel, counteracting the hydrostatic pressure that's trying to push it out.
Well, the volume expansion is much more efficient.
Theoretically, it's 1-to-1. You give 500 milliliters of an isooncotic colloid, you get 500 milliliters of volume expansion. If you use a hyperoncotic colloid, like 20% albumin, you can even pull fluid from the tissues into the blood, expanding your volume by more than what you infused.
Let's look at the specific agent, starting with the gold standard, albumin.
It's the reference standard. It comes from human plasma donors. It's heat-treated to kill viruses. It's monodisperse, meaning all the molecules are the same size, which gives it a predictable effect. It also has other functions, like acting as a transport protein.
But the big problem is cost and availability.
Very expensive, and the supply is finite.
Okay, next up, the gelatins.
These are derived from degraded bovine collagen. The common examples are gelafusine, which is a succinylate gelatin, or the older hemicel, a urea-linked gelatin. They have a smaller molecular weight, around 30 to 35 kilodalton.
Does that mean they leak out faster?
It does. The half-life in the circulation is quite short, maybe 2 to 3 hours. They're primarily excreted by the kidneys. But the big exam point for gelatin...
Anaphylaxis.
Exactly.
Wow.
Gelatins have the highest rate of anaphylactic reactions among all the colloids. You must mention that.
Okay, what about the dextrans?
These are glucose polymers produced by bacteria. You get dextran 40 and dextran 70, named for their molecular weights in kilodaltons. We rarely use them for pure volume resuscitation now because of their side effects.
And what are those main side effects?
2 big ones. First, they coat platelets and decrease the factor A von Willebrand factor complex, which causes bleeding. Second, they can cause an osmotic renal failure by precipitating in the tubules.
I have seen vascular surgeons use dextran 40, though.
Yes, that's a niche use. They like it because it reduces blood viscosity and can help prevent thrombosis in small vessels, like in microvascular surgery or free flaps.
And finally, the really controversial one, hydroxyethyl starches, HES.
Yes, the starches. These are modified natural starches from maize or potatoes. We classify them by molecular weight and degree of substitution. The older ones, like hetastarch, were very large and stayed in the body for weeks. The newer ones, like tetrastarch, brand name Voluvin, are smaller and are metabolized faster.
But they've really fallen out of favor. Why?
Major safety concerns. Several large randomized controlled trials, and you should name them, specifically the 6S trial in Scandinavia and the CHESS trial in Australia, showed that HESs was associated with an increased risk of acute kidney injury and a need for renal replacement therapy.
Especially in septic patients.
Yes, particularly in sepsis. That was the nail in the coffin for their routine use in the ICU.
So if I'm asked about the complications of colloids in general, what's my list?
Okay, 4 key points. 1, anaphylaxis, highest with gelatins than dextrans. 2, coagulopathy, mainly with dextrans and the high molecular weight starches. 3, renal dysfunction. This is the big one for HES, this osmotic nephrosis. The molecules are taken up by renal tubular cells, causing them to swell up and obstruct urine flow.
And the fourth?
A strange one, pruritus. Severe intractable itching because HES molecules deposit in cutaneous nerves. It can last for months after the infusion.
Wow. Okay, section 5. This is another very high-yield section, especially for the written paper. The comparison. You said I need to draw a table.
You must draw a table. Visualize 2 columns, crystalloid on the left, colloid on the right. Now let's fill in the rows. First row, composition.
Small molecules and ions versus large molecules like proteins or starches.
Good. Next row, volume effect.
Poor, with only about 20% remaining intravascular, versus good, with 100% or more remaining intravascular.
Next, ratio for blood loss replacement.
3-to-1 for crystalloids versus 1-to-1 for colloids.
Good. Duration of action.
Short, just minutes for crystalloids versus long, hours for colloids. Cheap versus expensive.
And finally, the most important row, risk profile.
For crystalloids, it's tissue edema and with saline metabolic acidosis. For colloids, it's anaphylaxis, renal injury, and coagulopathy.
Perfect. If you draw that table, you will get marks.
And now the ultimate question, the one that's been debated for decades. Which one is actually better for the patient?
For this, you have to cite the evidence. And the landmark trial is the SAFE study. That stands for Saline versus Albumin Fluid Evaluation. It was a huge trial in Australia and New Zealand.
And what was the bottom line?
In a general ICU population, there was no difference in 28-day mortality between patients resuscitated with albumin and those resuscitated with saline.
So if survival is the same, and saline costs a tiny fraction of what albumin costs.
Crystalloids win on cost effectiveness for the general population.
Yeah.
However, and this is key for the exam, the subgroups matter.
Okay, what did the subgroup analysis show?
In patients with sepsis, albumin showed a trend toward reduced mortality. This was later supported by the Albios trial, which showed it was beneficial for hemodynamic stability and septic shock.
And in trauma?
No significant difference in general trauma. But in traumatic brain injury, TBI, this is the kicker, albumin was associated with higher mortality.
Why on earth did albumin kill brain injury patients?
The theory is about the damaged blood-brain barrier. In TBI, the barrier becomes leaky. The albumin molecules, which are normally kept out, leak into the brain parenchyma.
And they would pull water with them through osmosis.
Exactly, increasing cerebral edema and raising intracranial pressure. So the absolute exam rule is no albumin in TBI.
That's a critical point. So let's move to section 6 and apply this knowledge. Role in clinical scenarios. I'll give you a case. You tell me the fluid strategy.
Let's do it.
Case 1. A 25-year-old male, motorcycle accident, BP is 80/50, heart rate is 120, likely has a ruptured spleen.
Okay, this is hemorrhagic shock. First, 2 large-bore IV cannulas. Second, you start with an initial bolus of a warmed isotonic crystalloid. Ringers or Plasmalyte would be preferred to avoid acidosis, but saline is acceptable.
And how much do I give?
The key here is not to over-resuscitate with clear fluids. If he's still unstable after 1 or 2 liters, you need blood. The concept is permissive hypotension, aiming for a systolic of 80 to 90 until the surgeon gets surgical control to avoid popping the clot.
What about colloids?
You can use them as a bridge if blood isn't immediately available just to maintain perfusion, but you must limit the dose due to their effects on coagulation. Blood products are the definitive colloid in trauma.
Okay, case 2. A 65-year-old female with pyelonephritis. She has a high fever and her BP is 70/40. Septic shock.
Here, you reference the Surviving Sepsis Campaign guidelines. Step 1 is a 30 milliliter per kilogram bolus of crystalloid within the first 3 hours. For an average adult, that's about 2 liters. Then you start vasopressors, like noradrenaline, early. Now, if she requires very large volumes of crystalloid and is still hypotensive, or if she's developing significant edema, that's when you add albumin.
Then what do you absolutely not use?
You do not use hydroxyethyl starch. It is contraindicated in sepsis due to the high risk of kidney failure.
Got it. Case 3. A 40-year-old male with a significant head injury. His GCS is 8. He's been intubated.
The goal here is to maintain cerebral perfusion pressure and avoid secondary brain injury. The fluid of choice is 0.9% normal saline.
Why saline specifically?
Because it is slightly hypertonic compared to brain cells. Its osmolarity is 308, while plasma is about 290. This helps to draw water out of the brain and prevent cerebral edema.
And what do you avoid?
You avoid Ringer's lactate because it's slightly hypotonic with an osmolarity of around 273. And you absolutely avoid dextrose and albumin based on the safe study data we just discussed.
Right. Final case. Routine major abdominal surgery, say, a Whipple's procedure.
Here, you would use a balanced salt solution like Plasmalyte or Ringers to avoid the hyperchloremic acidosis from large volumes of saline. But the modern strategy is goal-directed therapy, or GDT.
Explain that.
Instead of blindly giving fluids based on a formula, you use a monitor like an esophageal Doppler or a pulse contour analysis system to measure stroke volume. You then give small 250 milliliter boluses of either crystalloid or colloid to see if it increases the stroke volume. You're trying to find the top of the patient's Frank Starling curve.
You're optimizing their cardiac output.
Exactly. This optimization has been shown to improve outcomes, reduce complications like gut edema, and shorten hospital stays.
That's very clear. Now, section 7, complications. If I get a short note on complications of IV fluid therapy, what's my list?
Okay, here are the 5 headings. 1, fluid overload. This is the most common. It leads to pulmonary edema, peripheral edema, and what we call splanchnic edema, a swollen gut, which causes ileus, and can even lead to abdominal compartment syndrome. 2, electrolyte disturbances. Hyperchloremia from saline, hyponatremia from hypotonic fluids. You could mention hyperkalemia as a theoretical concern with Ringers and renal failure, though it's often overstated.
3, coagulopathy.
Yes. This can be dilutional from just washing out the clotting factors, or it can be a specific inhibitory effect from colloids like dextrins and starches.
4,
4, renal dysfunction. This is a tricky one. It can be caused by volume depletion, of course, but also by volume overload. High venous pressure leads to renal venous congestion, which reduces renal perfusion. And then you have the specific toxicity from HES.
And the last one.
5, hypothermia. If you infuse liters and liters of room temperature fluid into a patient, especially in trauma, you will drop their core body temperature. Hypothermia worsens coagulopathy and acidosis, which is the triad of death. Always warm fluids and major resuscitation.
Excellent. Section 8, current trends. How do I sound cutting edge in the Viva?
The main trend is that less is more. We are moving away from the old liberal fluid strategies, drowning the patient towards restrictive or zero balance strategies, especially in the context of ERS or enhanced recovery after surgery.
And pharmacologically?
Pharmacologically, the trend is away from 0.9% saline and towards balanced solutions. There are big trials like the SMART and SOLT-ED trials that support this. And for colloids, the era of synthetic colloids is essentially over. HES is banned or heavily restricted in many contexts. The pendulum has swung back firmly to crystalloids for most indications, with albumin reserved for very specific situations.
Got it. Section 9, my favorite. Exam traps. These are the questions the external examiner asks while looking over his glasses at you.
Okay, trap number 1. The examiner will lean back and ask, tell me, what is the ideal IV fluid?
And the answer is not blood.
The answer is, sir, the ideal IV fluid does not exist. Then you describe its properties. It would have a predictable and sustained volume effect, no metabolic side effects, no toxicity. It would be cheap and stable at room temperature.
Trap 2.
Can you use Ringer's lactate in a diabetic patient? It has lactate in it.
And the answer?
Yes, sir. Lactate is not glucose. It is a buffer precursor and is metabolized via a different pathway. Ringer's itself does not contain glucose and will not cause hyperglycemia.
Okay. Trap 3.
Why can't you mix Hymocell, that's a gelatin, with a blood transfusion?
I think I know this one. Something about calcium.
Exactly. Because older formulations contain a high concentration of calcium, which could cause clotting with the citrated blood in the bag. Modern formulations are safer, but the classic teaching is to avoid mixing them.
And one more.
Explain the J-curve of Starling. This is a more advanced one.
What's that?
It refers to a graph from the revised Starling model. Filtration rate is on the y-axis, and capillary pressure is on the x-axis. The curve shows that as pressure drops along the capillary, filtration stops, but reabsorption does not occur. The curve flattens out, it doesn't go negative. That's the J-shape. It demonstrates the importance of the Glycocalyx barrier.
Brilliant. Section 10. Diagrams. You can't just write text for 20 marks.
You absolutely cannot. You must practice drawing these 3 diagrams. First, the box diagram of the 60-40-20 body fluid compartments. Make it neat. Label the volumes for a 70-kilogram man.
Second.
The capillary diagram. Draw a tube showing the endothelial cells. Crucially, draw a thick, fuzzy glycocalyx layer inside it and label the subglycocalyx space. Then draw your arrows for hydrostatic and oncotic pressures.
And the third is the table we already discussed.
The comparison table. A neat, ruled table comparing crystalloids and colloids on those 5 or 6 key points we went through. It breaks up the text and shows the examiner you are organized.
And finally, Section 11, the conclusion. How do I wrap up this massive answer?
You need a polished summary statement that ties everything together. I'll dictate one for you. Ready?
Ready.
In conclusion, intravenous fluid therapy is a fundamental component of perioperative care that requires a nuanced understanding of physiology and pharmacology. While crystalloids, particularly balanced salt solutions, remain the primary resuscitation fluid due to their safety and cost profile, colloids play a specific volume-sparing role in certain clinical states like sepsis. The choice of fluid must be individualized, considering the patient's specific pathology, such as TBI versus sepsis, and should be guided by dynamic monitoring to avoid the significant morbidity associated with both hypovolemia and fluid overload.
That is perfect.
Yeah.
It shows you're not just following a recipe, you're thinking like a clinician.
That's the goal.
Let's do a quick lightning recap for the listener to take into the exam hall. I'll try. 1, TBW is 60% of lean weight.
Good.
2, revised Starling means no venous reabsorption. It's all about the lymphatics. 3, the glycocalyx is the gatekeeper.
Yes.
4, normal saline causes hyperchloremic metabolic acidosis.
Yeah.
5, Ringer's lactate is balanced because the lactate gets converted to bicarb. 6, it's a 3-to-1 replacement ratio for crystalloids, but 1-to-1 for colloids. 7, avoid HES in sepsis and renal failure.
Crucial.
8, avoid albumin in PBI. And 9, treat fluid like a drug.
You've memorized that well. You're ready.
I had a good teacher. This has been a massive deep dive, specifically tailored for the Gujarat University MD curriculum. We really hope this helps you crush that exam.
Don't panic. Draw your diagrams. Quote the physiology. You will do fine.
Before we go, as always, here is a provocative thought. We've been treating the Glycocalyx like a simple barrier. But what if we started treating it like an organ?
Go on.
It covers the entire surface area of the vascular tree. That's the size of several tennis courts. When we rapidly infuse fluids or cause hyperglycemia or allow inflammation to run rampant, we physically strip this layer off. Endothelial shedding is a real measurable marker of mortality and critical illness.
You're saying that.
Maybe the future of fluid therapy isn't about the volume in the bag at all. Maybe it's about endothelial protection strategies. Which fluids, which drugs, which techniques can we use to protect and even regenerate this fragile, vital organ? Just something to mull over.
Fascinating. It changes the whole perspective from filling a tank to protecting the pipes.
Exactly. Good luck with the exams. You've got...
Good luck. Go get that MD.